Good morning. My topic is comparative study, magnocellular stimulation versus occlusion therapy, a prospective case control study in amblyopia treatment. Amblyopia is a developmental disorder of spatial vision affecting 2 to 5% of the global population. The current gold standard treatment for amblyopia is occlusion therapy, that is patching of the dominant eye to stimulate the amblyopic eye, where the success rates was found to be 50 to 75%. Major limitations of the current therapy includes treatment adherence, psychological impacts, and practical difficulties when amblyopic eye vision is reduced severely. Coming to the newer approach, that is magnocellular stimulation, Dr. Santan Gopal et al. He discovered an orthoptic magnocellular stimulator which showed an improvement of 64% improvement in visual acuity and 97% in stereo acuity, and the mechanism was based on magnocellular stimulation. And the principle behind the magnocellular stimulation was maximum foveal stimulation was seen during the initiation of saccades, which was studied from a series of 5 positron emission tomography experiments. Now coming to the parvocellular pathway, which is the major pathway for occlusion. When light falls on the fovea, the parvocellular ganglion cells gets activated and information is passed to the lateral geniculate body. And from there it reaches the 4C beta area of the primary visual cortex where the foveal stimulation occurs. And coming to the magnocellular pathway, which is the major pathway for the orthoptic device, here when the stimulus is transmitted at the fovea, the M ganglion cells transmits the information to the lateral geniculate body, that is 1 and 2 areas of the lateral geniculate nucleus. From there it again reaches the primary visual cortex area 4C alpha, which is further processed in the posterior parietal cortex. And also information from the frontal eye field and posterior parietal cortex again comes back to the primary visual cortex where the foveal stimulation occurs. Aim and objective: to study and compare improvement in visual acuity with magnocellular stimulator and occlusion therapy in the management of amblyopia. Secondary objective is to see the improvement in stereopsis. It was a hospital-based randomized prospective case control study. Patients diagnosed with amblyopia attending the pediatric ophthalmology clinic from May 2023 to November 2024 were included. Amblyopic children of age group 5 to 12 years, refractive amblyopia, strabismic amblyopia, and visual acuity less than 6 by 12 vision, and those not undergone occlusion therapy in the past 6 months were included, and those with defective vision due to trauma to eyes, deprivation amblyopia, and defective vision due to retinal and optic nerve pathologies were excluded from the study. Target population of 81, that is 41 in the occlusion and 40 in orthoptic groups of age group 5 to 12 years were taken for the study. Consecutive sampling done divided alternatively into both the groups. Snellen visual acuity values were recorded and converted to their corresponding logMAR values. Stereo acuity was measured using TNO test wearing red-green goggles and was graded. Now, occlusion therapy protocol based on the pediatric eye disease investigator group. 2 hours of daily patching was advised, which was monitored by parents. And magnocellular stimulation protocol, the orthoptic device protocol involves 30-minute structured 2 programs with LED light tracking exercises. And the 2 programs each consist of uniocular movement of 800 times and binocular movement 500 times. Total duration includes 7 months for a total of 17 sessions. And follow-up occurs at the end of 1st, 3rd, 5th, and 7th months for the parameters of best corrected visual acuity and stereo acuity. Now, 41 eyes in the occlusion group and 40 eyes in the orthoptic group with amblyopia of age group 5 to 12 years were included in the study, and the study was statistically analyzed by statistician. Assessment of change of best corrected visual acuity at different time points in the occlusion group showed that a significant and consistent improvement in visual acuity from baseline, and that of the orthoptic group also showed a significant and consistent improvement in visual acuity from baseline. When comparing the best corrected visual acuity between the 2 groups, at 1 month we saw that the orthoptic group showed a statistically significant improvement over the occlusion group. Beyond 1 month, both groups continued to improve, but the difference between them was not statistically significant. Now, change of stereo acuity from baseline at different time points in both groups showed that occlusion showed a gradual improvement in stereo acuity. Orthoptic group showed a more rapid and significant improvement in stereo acuity. Now, comparison between the stereo acuity between 2 groups showed that the improvement in stereo acuity observed in the orthoptic group was found to be statistically significant compared to the occlusion group. The study was done to compare the benefits of orthoptic magnocellular stimulation with occlusion therapy in children with amblyopia in the age group of 5 to 12 years. The percentage of children having improvement in visual acuity from our study showed that there was 87.8% improvement in visual acuity with the occlusion group and 85% with the orthoptic group. Now, the percentage of children having improvement in stereo acuity from our study showed that 77.5% improvement was seen with the orthoptic group and 29.3% improvement was seen with the occlusion group. Now, improvement in best corrected visual acuity at 1 month, the orthoptic group showed a statistically significant improvement over the occlusion group. But at 7 months, both the groups showed almost similar improvement, that is 87.8% in occlusion and 85% in orthoptic. Now, coming to stereo acuity, a substantial improvement in stereo acuity was found in the orthoptic group throughout the study. That is 77.5% for orthoptic and 29.3% for occlusion. The superior stereo acuity outcome in the orthoptic group is attributed to the binocular approach of the therapy and higher compliance, as each session was done and monitored at hospital. The strength of the study was no other similar comparative study was available in literature and was able to monitor at hospital. Limitations of the study: difficulty to recruit children as they have to come to hospital daily for the sessions, and small sample size and follow-up time was limited. So conclusion, the improvement in visual acuity in orthoptic group was higher in the first month, though at the end of 7 months was almost similar in both the groups. Stereo acuity improved in both the groups, but the improvement seen in orthoptic group was significant, that is 77.5% when compared to occlusion group, which was 29.3%. So our recommendations are: increasing the frequency of sessions in the orthoptic group over the last 4 months could have led to a better improvement. Longer follow-up is necessary to evaluate regression of vision after stopping the treatment. Thank you.
Good presentation. So you have 7 months follow-up.
Yes,
Are you
ma'am.
planning to further follow up the patients?
Yes, ma'am.
For how long?
Actually, my study protocol duration was limited, so we were not able to assess whether there was, after stopping the total 17 sessions were there. So after stopping the sessions, we were not able to. We didn't have time to look for the regression of the vision. So we are planning to improve
Further.
to
Follow the patients
call the
further.
patients back for follow-up, and so that initially our orthoptic device has a daily for the first weeks we had daily sessions, and then weekly ones, 2 weekly ones. Then after that we are having each session with a gap of 2 month interval. So in this study was shown that in the first period there was rapid improvement. So we are planning to incorporate more sessions in the final duration of the treatment also.
So that will benefit the
Yes.
patients.
Amblyopia is not one, no. So there are various subgroups of amblyopia. So we should see each subgroup independently.
Yes,
like
sir.
you can have 4 assorted groups,
Yes.
4 pure groups of different types of amblyopia, like strabismus, mechanism, and like that, and then see whether how it works.
Okay, sir.
And the third group of both combined, both orthoptic and occlusion, that kind of one group should also be there.
Okay, sir.
Because we know that both are independently working.
Yes.
And both are easily doable in a child of that segment. So you can as well add one group and
Yes.
prove that that works very effectively than the other pure
Okay, sir.
individual groups. Okay.
Okay, sir.
Good.
Thank you, sir.